Assalamu alaikum. The primary treatment for laryngopharyngeal reflux in most clinical guidelines remains proton pump inhibitors, but the evidence supporting the use of proton pump inhibitors in all cases of laryngopharyngeal reflux remains weak and at best controversial. This presentation is on why proton pump inhibitors are not always indicated in cases of laryngopharyngeal reflux. Laryngopharyngeal reflux and gastroesophageal reflux disease are closely related, and their symptoms can overlap sometimes significantly. The symptomatic diagnosis of laryngopharyngeal reflux is based on composite symptom scores, like, for example, the Reflux Symptoms Index, which is structured in 9 different questions. One of them would reflect whether there is any gastroesophageal reflux symptoms or not, the 9th item. The other 8 items would ask on things like extraesophageal manifestation of reflux affecting the larynx, the pharynx, or the respiratory system. Questions like voice problems, throat clearing, difficulties, postnasal drip, or excess mucus in the pharynx, difficulty in swallowing, coughing, or after meals, or annoying cough, difficulty in breathing, or choking episodes. If the patient scores anything related to gastroesophageal reflux, anything moderate, and then he would require maybe 3 or 4 other items of these 8, moderate response for 3 or 4 other of these 8 to qualify for a positive reflux system index. You would need to get more than 13 to get a positive index. If the patient does not have any gastroesophageal reflux symptoms, then the term silent reflux is often used. Despite being closely related, LPR and GERD are distinct clinical entities. They are different. Different in the pathophysiology, affecting the lower esophageal sphincter in GERD and the upper esophageal sphincter as well in LPR, in the major irritant, which is hydrochloric acid in GERD and pepsin in LPR, in the timing of the symptoms, which is usually daytime in LPR and nocturnal in GERD, in the reflux exposure time, the time required to evoke symptoms, which should be less than 5% of the 24 hours in GERD, that is to say about 1 hour a day, but much less time is required to evoke a response and symptoms in LPR, maybe few minutes. And in the tolerance of the end organ, the reflux defensive mechanisms of the esophagus are much better suited than they are in the larynx or the pharynx. There are, of course, also differences in the physical findings with laryngoscopic features in LPR and esophagoscopy findings in GERD, and in the 24 hours pH monitoring, which will also show some differences between the two. But they are also different and very different in the way they respond to treatment. And primarily the proton pump inhibitors dosage and duration are different in both conditions, and also the percentage of success is very different. For example, in a large series of LPR patients, it was seen that throat clearing is predominant in laryngopharyngeal reflux at more than 87% of the patients, whereas it's very rare in patients with GERD, only 3%. On the other hand, patients in GERD would have 83% of them would have heartburns, but only 20% of patients of LPR would describe GERD. The medical treatment of LPR across the world is very similar in Europe, in North America, in Asia, and in Africa or South America. There is no, as yet, a drug that acts directly against pepsin. So what we are doing is treating these patients with proton pump inhibitors, either in once daily or twice daily dosages, giving them alginate reflux suppressants, antacids, sometimes H2 receptors antagonists, and advise about diet and lifestyle changes. And these are the main components of the treatment, which is similar with slight variations in the proportions between different parts of the world. This treatment should be taken for at least 3 months before you notice any improvement of the symptoms, but the laryngeal findings will generally take at least 6 months before they start to ensue. If there is no response to the treatment, this should not lead to an increase in the dosage or increase in the duration of the treatment, but rather would invite a revision of the diagnosis or perhaps consideration of other methods of treatment, including surgery. Gastroesophageal reflux disease responds quite well to the treatment with proton pump inhibitors, but the response of laryngopharyngeal reflux to proton pump inhibitors is at best variable. The way the proton pump inhibitors works in LPR is indirect. It's not a direct effect like in gastroesophageal reflux disease. It works by preventing the cleavage of the pepsinogen into active pepsine. Acidity is required to initiate such a step. So by preventing the acid production, it prevents the activation of pepsin. The divergent results of PPI in laryngopharyngeal reflux could be explained by any of these several factors. LPR patients are a mixed group of patients with symptoms affecting either the larynx, the pharynx, the aerodigestive tract, the chest, sometimes the sinuses as well. So there's the heterogeneity of the patient. Also, LPR is always overdiagnosed, with disappointing outcomes of acid suppression therapy as a result of treating some patients who may not have LPR in the first instance. There is as yet some unrecognized subgroups of patients with LPR who respond better to PPI than others. There is also a very high response rate for placebos in trials of PPI in LPR patients. In controlled trials, you'd always see a very high response of placebo in the placebo group. This is possibly because there is a functional element in LPR that is as yet unrecognized, much like other functional gastrointestinal disorders who also have a high response rate for placebos. In addition, patients with non-acid or with mixed acid reflux of LPR reflux are resistant to high doses of proton pump inhibitors in more than half of the cases, and LPR patients require more aggressive and prolonged therapy with PPI compared to the gastroesophageal reflux disease patients. An important cause for failure to respond to PPI in laryngopharyngeal reflux patients is when PPI is used as a single daily dose rather than twice daily. This was first noted by Park et al. In 2005, who noted that there's a significant failure rate with the use of a single daily dose of PPI, basically because the currently available PPI drugs only work for about 12 to 14 hours of each day, and because in LPR mucosal damage can occur with a very short-lived reflux episode, 24 hours coverage is necessary, so twice daily doses is necessary. Park et al. had a trial of two groups, a group with a single dose and a group with 2 daily doses of PPI. The group with the 2 daily doses had a 50% response rate within 2 months of using PPI. The other group with a single dose had only a 28% response rate. When this group had a further 2-month period of PPI with twice daily rather than their initial once daily, their success rate increased to 54% of this group. So the ultimate combined success rate for the whole group was 70% after 4 months of treatment with 2 daily doses of proton pump inhibitors. Another important cause for failure of PPIs to control laryngopharyngeal reflux symptoms is the non-acidic laryngopharyngeal reflux. Pepsine is the causative agent for laryngopharyngeal reflux mucosal injury. It can cause mucosal injury and not only in the vocal folds as being shown in biopsies, but also in other laryngeal and pharyngeal cells. In addition, things like bile salts can also cause such damage. Pepsin is normally active at a low pH of 2, but can retain some activity even at a higher pH level of 6.5, a non-acidic medium. So in addition to acidic reflux, also weakly acidic reflux with the help of proton pump inhibitors, for example, or a mixed reflux can still cause mucosal damage in the larynx and in the pharynx. Pepsin remains adherent to the epithelial cells in the larynx and the pharynx for a while and is then endocytosed by these cells and remain inside the cells itself and can be reactivated later if they encounter lower pH levels. The cells were only exposed to pepsin for a very short while before they can endocytose pepsin inside them, as brief as 30 seconds or so. If this happens like 3 times in a week, then this would cause cell damage. The other important factor in the non-acidic laryngopharyngeal reflux is that they cause damage not only by the chemical injury of the pepsin, but also by neurological impact on the laryngeal sensitivity and also abnormalities of the upper esophageal sphincter. Reviewing and analyzing the literature for reports of efficacy of proton pump inhibitors therapy in laryngopharyngeal reflux will show 2 different patterns. These patterns are as such. The uncontrolled studies, most of the uncontrolled studies, will suggest a response rate of almost 70% to proton pump inhibitors. On the other hand, most of the controlled studies, placebo-controlled trials, had found no beneficial effect of proton pump inhibitors when compared with the placebo. We shall now go through several of these trial groups, including systematic reviews, meta-analysis, and large trials. Starting with this summary of 8 different trials, uncontrolled open-label trials. The 8 trials showed some significant improvement in patient symptoms after the use of PPI in the treatment of laryngopharyngeal reflux. Note that in 5 of these 8, the endpoint, the clinically significant measure for symptoms were not defined. But at the end of the day, these 8 uncontrolled trials suggested a benefit of the use of PPI. We have been already through the largest of these tables, the Park 2005 article on which he had tried PPI on a single or double doses in the treatment of LPR. On the other hand, a different pattern emerges from the randomized controlled trials, double-blind and placebo controls. This is an example of a systematic review of 7 of these controlled trials. 6 of them showed no improvement after the use of PPI or no difference between the results of the PPI and the placebo. Only one single trial showed some improvement with the use of the PPI over placebo. In all these 7 trials, the findings, the laryngoscopic findings or the symptoms, or even the pH monitoring could not predict who is going to be helped with the PPI and who will not. I shall go through in more details on this article that showed some response and on the largest article of this series as well. Up to 2006, in the last systematic review, the only double-blind randomized controlled trial that claimed a statistically significant effect of proton pump inhibitors was this article, in which 22 patients were randomized into a group taking lansoprazole 30 milligrams twice daily or a placebo group. 2 patients dropped, but the final results included them as well. The final results for the 22 patients were 6 out of the 12 patients on the lansoprazole group had improvement, and only 1 patient in the placebo group had improvement. So these are the 22 patients. A 2x2 chi-square test showed statistically significant difference, with the lansoprazole group showing obviously more effect. But in fact, if the correction, the Fisher exact correction for the 2x2 table is used rather than the chi-square test, these results would not be significant at this level because of the small numbers in the 2x2 table. The largest trial up to 2006 was this trial of 145 patients randomized into two groups, a group using esomeprazole 40 milligrams twice daily or a placebo. And in this trial, the results were non-statistically significant between the two groups. This included the primary outcome for the main presenting symptom, and also improvement of the laryngeal findings or relief of the quality of life score. There was no difference between the two groups in this largest trial. And then came three more controlled trials. Two of these controlled trials were measuring the effect of proton pump inhibitors against the placebo in controlling voice problems or chronic cough using esomeprazole, and found no difference between using the proton pump inhibitor or the placebo. The third trial did show a difference, did show that rabeprazole was superior to the placebo in controlling the symptoms of LPR. And then Kadir et al. Had produced a meta-analysis of 8 randomized controlled trials, including some of the trials in the previous systematic review. In these meta-analyses, they pooled the results of these 8 trials and showed that the success rate for the proton pump inhibitors group was about 50%. That is to say 98 patients out of the 195 patients. The placebo group had a success rate of 41%. They concluded that there was no significant symptom reduction with proton pump inhibitors versus the placebo, and also there was no significant clinical predictors, either symptoms or signs of who is going to respond better to the proton pump inhibitors and who is not going to have any effect. Furthermore, when a funnel plot analysis was carried out on this meta-analysis to explore more heterogeneity and bias, two studies were outside the funnel. Both these two studies, one of them we had already been through, had claimed benefit of PPI against placebo. These two trials were actually outside the funnel plot analysis. In 2007, Gata et al. Produced another meta-analysis, including 4 of the randomized controlled trials previously used by Kadir. The pooled results had showed that the treatment group with the proton pump inhibitors had a 25% success rate, where the placebo group had a 21.4% success rate. The difference is statistically non-significant. The important thing is that when they calculated the numbers needed to treat in order to achieve any benefit of the proton pump inhibitors over placebo, is the 53 patients would need to have the proton pump inhibitors before one of them showed improvement more than the placebo group. So proton pump inhibitors, according to this, was no much better than the placebo group. And again, the funnel plot analysis showed asymmetry, suggesting a publication bias. And then came a systematic review up to 2018 of 9 trials. 6 of them showed no improvement of proton pump inhibitors over placebo, while 3 showed that proton pump inhibitor therapy is significantly improved the LPR. So 6 no improvement and 3 had showed some improvement, but there was no difference in the laryngoscopic findings between the two groups. And then in 2021 came one of the largest randomized controlled trials on the treatment of laryngopharyngeal reflux with proton pump inhibitors. This was conducted on 346 patients in the UK, multi-centers in the UK. Patients were randomized into 2 groups, a group receiving 30 milligrams of lansoprazole twice daily, and the other taking a placebo twice daily for 16 weeks, and this showed no difference the lansoprazole had no benefit over the placebo in any of the outcome measures. So the data from the controlled trials support this pattern that the proton pump inhibitor therapy results are very much comparable to results of the placebo, and that neither the symptoms nor the laryngoscopic findings of the patients could precisely or reliably predict the response to the proton pump inhibitor therapy, tell us which patient is going to benefit and who is not going to benefit from the therapy. Except perhaps that this emerging notion that if the patient does not complain from the typical symptoms of GERD, he is unlikely to benefit from proton pump inhibitors therapy for LPR. Surprisingly, despite this pattern, the empiric treatment with PPI for 2 to 3 months is still recommended in clinical reviews and guidelines as a cost-effective and useful approach to the initial diagnosis of laryngopharyngeal reflux. The other interesting pattern is the very high response rates of the placebo group in trials involving the LPR suspected patients. This very high response rate is much higher, for example, than the placebo response rates in trials of GERD. These high response rate, like if patients with LPR are giving just a placebo, can have a high response rate comparable to the high response rates in functional GI disorders, which may suggest a complex and multifactorial cause for LPR. It may not be just the chemical injury caused by the pepsine. There may be other underlying factors like functional elements in the etiology of LPR. The other thing is when no controls are used, when it's only a single group, we usually have a better results with the treatment of the proton pump inhibitors, because the placebo, the hidden placebo effect would take place. There would be a placebo enhanced spontaneous resolution into this single group report. And we still need to identify subgroups of patients with reflux-associated laryngeal symptoms, like LPR suspected patients, to know who might benefit and who will not benefit from the treatment of proton pump inhibitors. And finally, to sum up, the efficacy of proton pump inhibitors in laryngopharyngeal reflux patient is still at best controversial, especially in patients with non-acid or mixed acid laryngopharyngeal reflux who are resistant to even high doses of proton pump inhibitor therapy in as more than 50% of the cases and up to 3/4 of the cases. In these groups of patients, the treatment must include alginate reflux suppressants, perhaps combined with antacids, and not always proton pump inhibitors. Proton pump inhibitors, on the other hand, is still the primary medication for acidic reflux, and proton pump inhibitor therapy for laryngopharyngeal reflux will continue, even though the existing evidence is poor and comes mainly from individual uncontrolled studies. By this, we come to the end of this presentation on the efficacy of proton pump inhibitors in the treatment of laryngopharyngeal reflux. Assalamu alaikum.